Good evening. Dear ESTS members and webinar attendees, I'm very sorry because of the technical problems, but this website was unstable during the last 5 minutes. My name is Wiggen de Piepere. I'm your moderator for today. This webinar is the third one of the third season of the ESTS educational webinars, and the subject today is esophageal squamous cell carcinoma, with a specific question on whether we should go for definitive chemoradiation or surgical resection in some cases, or can we find a way in between? Therefore, we invited two experts in the field to comment on our cases today. The first expert is Professor Karin Haustermans. She is a radiation oncologist and she is the medical director of the Belgian Proton Therapy Center Particle, and she is secretary of the Leuven Cancer Institute at our university hospital in Belgium, Gasthuisberg. She is full professor at the Catholic University of Leuven, and she specialized in GI and GU oncology. She's a member of several national and international scientific organizations, and she is a co-author of the European Society of Medical Oncology Guidelines on the treatment of esophageal cancer. Welcome, Professor Haustermans. The second expert is Professor Xavier Benoit D'Journo. He's a thoracic surgeon and full professor of thoracic surgery at the Aix-Marseille University in France. As a thoracic surgeon, he has a special interest in esophageal surgery with many publications on that topic. He's also the associate editor of Diseases of the Esophagus, and he is a faculty member of the ESTS minimal invasive esophagectomy courses. Also, welcome to you. We will ask a lot of interactivity of the audience, so be ready to answer the poll questions, and please ask as many questions to the expert. So we are almost 80 people right now. This is great. I hope the technical problems are solved. The quality of the sound is poor, people say. I also have a kind of feedback. I don't know if in the speakers we have the sound too loud. I don't know if you can do something on that.
Maybe we should try to mute if you don't speak.
Yeah, we can try that.
And me, you hear me? You hear me?
Yeah.
Okay.
We hear each other, and now the feedback is, yeah, there's still feedback.
Why is not muted yet, I think?
Sorry?
Are you muted?
No, it's okay for me. It's,
yeah,
I'm connected.
Try to mute for a second.
Do you hear me?
I hear you, yes. And you try to mute for a second. Okay. Now the sound, now the echo is gone. So the echo comes from your computer, I think. So on the moment you want to talk, you can just unmute again. Okay. So now it's better, indeed. Let me start with the first case. I'm gonna try to share my screen without falling off again. Okay, I think everyone can see this. Now I need to be able to proceed. Yes. So this is about a patient of 72 years old, a male patient who had dysphagia for at least 2 months. 10 years smoking history, but this was 30 years ago, and no significant alcohol intake. The patient is from Eastern Turkey, which is a mountainous area with a tradition of excessive hot tea drinking and consumption of cheese with herbs rich in nitrosamines. The patient has emphysema in the lungs and has a BMI of 90. He has no other health issues. The endoscopy, the history starts in the beginning of February 2020. In the endoscopy, we see a tumorous ulcer at 32 centimeters from the incisors. It is 3 centimeters long, and the biopsy shows us a well-differentiated squamous cell carcinoma. The PET-CT, I'll show you the lung windows and the mediastinal windows. So there's the emphysema and more emphysema. For the rest, that's not too many things. And then there with the PET scan, and you can see some lymph nodes in the hilum, and there was the tumor. Maybe I can go back. So here's the tumor, and there are some hilar lymph nodes, probably inflammatory. So this is what the PET-CT is showing us. Now we need to go on. Yep. So the first question to the audience: what would be the next step in the clinical stage T2, 3, N0, M0? A, curative chemoradiation. B, EBUS to evaluate the hilar lymph nodes. C, neoadjuvant chemoradiation followed by surgery. Or D, immediate surgery and Ivor Lewis esophagectomy. If you go to your right sidebar to the polls, you will see that the polls are popping up there. You should be able to see the first poll right now. So we are almost 90. This means that a lot of people can vote. We have about 30 people who voted, so we can have a little bit more. It's anonymous. We can just vote without any problems. We have 35 people who voted. We are more than 90. Please make your vote. You cannot do anything wrong. You can only learn. Some people are saying there's the connection. So you have questions, and then you have polls just next to it on the right side, and then people. In polls, you can find these polls, and there you can vote. But maybe we can already ask the experts what I think of the first question. So question 1, we think it's an T2, 3, and 0. But are we right or not? Just taking into account that the hilar lymph nodes. And what would you do? Let's start with, I don't know, Mr. Haustermans.
I think that there are several options here. The hilar lymph nodes, they will of course have an impact on the staging and on the treatment as well. If the EBUS turns out to be positive, then we are sure they're pathological. But if it's negative, it doesn't bring much. The SUV-value is low compared to the SUV-value of the primary tumor. So in my opinion, there is a reasonable chance that these are inflammatory nodes and not tumoral nodes. And then for the treatment options, I think A and C are both valuable options, because this is an old man with some comorbidity, and he has, provided the lymph nodes are negative, a small tumor. So I think he has a very high chance of being cured by chemoradiation. And in case we do not succeed, there is still the option of salvage surgery. But of course, to do pre-op chemoradiation, assess response, and then only operate in case he doesn't have a clinical complete remission is certainly also an option, in my opinion. I would not go for straight surgery.
Okay. Professor D'Journo?
Good evening, everybody. I totally agree with you, Karin. Probably I would suggest first to try to check the lymph node metastases. Probably it remains inflammatory lymph node, and probably based on the fact that the patient is young, he has no competitive comorbidity except emphysema, but we have no respiratory function test. So probably I would suggest neoadjuvant chemoradiations, reassessment, and in case of complete response, a very strict surveillance protocol. And if is no responders to neoadjuvant chemoradiations, such as cross trial, probably to propose surgery. Surgery frontline, no, because it's a tumor T2, T3, and 0. So surgery at the first line is not a good option. And the second point is probably to have time with neoadjuvant treatment to make some preoperative renutrition and rehabilitations before going on surgery.
Okay. Would it make a difference if the EBUS turns out to be positive or negative, or actually not? Would you have another radiation field? Would you?
Radiated volume would, of course, become larger, and also the patient would have a more advanced stage and a worse prognosis. Standard, we don't include higher lymph nodes in our irradiated volume. So it will certainly have an impact, and the larger the volume we irradiate, the more pronounced toxicity, and especially if you go to surgery afterwards, the risk of postoperative lung complication is significantly higher if the volume irradiated is larger.
Okay, there's a question from the audience.
If you have the evidence that the mediastinal lymph nodes are positive, probably it changed my mind and probably go for definitive chemoradiations, because it's a T3 and 1, probably and 2 disease. So if the positives, if the lymph nodes remain positive, I will change my mind and probably go for a definitive chemoradiation.
There's one question from the audience, from Philippe Nafteux. Do we have an idea what the risk is of having involved hilar lymph node invasion in this squamous cell carcinoma? Because yeah, indeed, hilar, it's not standard in the field. It's not something we see that often, I think.
In my opinion, it's very low. My estimate would be below 10%.
Okay. Good. Let's go back to the case then. Right, I have to share my screen again. So the decision here in this case was made for for curative chemoradiation. So this patient underwent dynamic IMRT with a total of 5,100 centigrades of radiation. 6 times weekly, he had paclitaxel and carboplatinum. After this, a contrast thoracoabdominal CT scan was performed in May. And again, we saw giant bullae at the right and the left apex, the largest 45 millimeters in size, lung nodules in both apices, both stable, thickened esophageal wall in the distal third, minimal dilation of the esophagus, and most likely radiotherapy-related thickening of the esophageal wall. The patient had no dysphagia or symptoms, and there was the corona pandemic time, of course, and the patient decided to wait 2 more months. This was what we had. And then after 2 months, so the beginning of July, we had a new PET-CT and an endoscopy, and there was no uptake in the distal esophagus. So complete response, complete metabolic response. Hilar lymph nodes were stable or unchanged. There was no obvious tumor by doing the endoscopy. There was a 2 millimeter nodule in the distal esophagus. There was biopsied, and biopsy shows chronic inflammation of squamous mucosa, probably radiotherapy related, so no squamous cell carcinoma. And these are the pictures. Again, the bullous emphysema, and then I go straight to the PET. Images. Which is a bit difficult, but indeed we could not appreciate any higher uptake in the esophagus. Okay. What would be the next step? Follow up, being CT every 3 months and endoscopy and PET-CT to see if there's any progression. B, adjuvant chemotherapy. C, esophagectomy, or D, EUS evaluation. You can vote. I'll try to come back to you. Okay, in the meanwhile, we had another question from Professor Haustermans. What would you irradiate? What would be your fields and the technique you would use?
So we developed guidelines, multi-center guidelines, which will be published soon in the Green Journal, Radiotherapy and Oncology, the Radiotherapy Journal of Europe and Asia. And there we agreed that it's the, first of all, you should do a 4D CT in the treatment position, which is with the arms above the head. And then first you delineate the GTV, so the gross tumor volume like you see on the imaging. Then you make the CTV, which means you add 3 centimeters above and below the primary tumor. And we also delineate the perioesophageal lymph nodes within the CTV. And then we look at the different phases of the 4D CT, and we create an internal target volume to correct for motion related to breathing. This volume we treat with at least 7 beams. We did a study on arc therapy, but with arcs, in our experience, we see too high dose to the lungs, as we know, especially in the pre-op treatment, that post-op lung complications are related to the low dose volume. So the doses 5 gray, around 5 gray to the lungs. And if you use arcs, then it's very risky to have this low dose on the lungs. So that's why we chose for 7 beams. Regarding the dose, this is a really very difficult question. If you go for definitive chemoradiation, there was one randomized trial looking at 50.4 versus 66, and the 66 was actually maybe even inferior to the 50.4. Whether this is related to toxicity is unclear from the study. It's also an older study. So I would try to go to 50.4 at least, maybe somewhat higher, but there is very little evidence for the total dose to be used in definitive chemoradiation in combination with chemo. And then for the pre-op, we give a somewhat higher dose than in the cross. The cross uses 41.4 in 1.8, and we use 45 like most studies in France and in UK. And in the recent study in the Netherlands, they also increased their dose to 45 gray instead of 41.4.
Okay, thank you. Very clear.
Karin,
In the meanwhile,
may I ask a question to Karin? What do you think about the protocol of these patients? He received a 6 cycle of carbotaxol and 50 gray. Is it a standard protocol for definitive chemoradiation?
I don't think it's a standard protocol for definitive chemoradiation. The total dose is not standard, and if I remember well, the dose per fraction is also not standard.
It was 1.7, yes.
Yeah, but again, there is very little evidence. The large randomized trials usually use 50.4 as the standard dose in definitive chemoradiation. It's not wrong to go higher, but there is not a lot of evidence, and it's pure the biology. The higher the dose, the higher the chance of tumor control, but also the higher the risk of complications.
Squamous cell carcinoma and in a definitive chemo radiations protocol, do you prefer Folfox or carbotaxol?
It depends on the patient. Our standard is carbotaxol, but if for one reason or another the patient cannot tolerate carbotaxol, we use Folfox, and we have very good experience with Folfox. And based on the French data, I think Folfox can certainly be an alternative for carbotaxol.
Okay, in the meanwhile, we have the results of the second poll, and there 2/3 of the people are in favor of just follow-up, and let's say 20%, 1 in 5, is going for the esophagectomy. Let's see what happened in our case. Share this again. The patient got a minimally invasive Ivor-Lewis esophagectomy. It was a 3-port laparoscopy and a uniport VATS esophageal approach. There were significant adhesions to the lung, which I can imagine. 160-minute surgery time, which was very fast in my opinion. Postoperative prolonged air leak, which I can also imagine. Subcutaneous emphysema. If you look at these lungs, this is not a surprise. And the patient got a Heimlich valve and was discharged. There was a prolonged air leak for 1.5 months, and the chest tube was removed in the outpatient clinic. The pathology revealed severe esophagitis with esophageal ulceration. There was a complete pathologic response of the primary tumor. 16 lymph nodes were retrieved in total, and 2 lymph nodes had were metastatic around the left gastric area. The biggest metastatic lymph node was 0.8 centimeters in size, associated with perinodal invasion. Viable tumor ratio was 60% in the metastatic lymph nodes. Surgical margins were negative for tumor, the proximal, the distal, and also the circumferential resection margins. Post-treatment stage was YPT0 in 1M0. So what would be your next step? Adjuvant radiation to the upper abdominal region, because there were the positive lymph nodes. B, no treatment, but follow-up. C, adjuvant chemotherapy. D, immunotherapy. You can vote again. I'll try to come back to you. Okay. In the meanwhile, there was the question, what would be the complications from irradiation? We already told about the lung complications.
I think we have to make a difference between postoperative complications and long-term complications from chemoradiation without surgery. The long-time complications from chemoradiation without surgery are mainly radiation pneumonitis and also cardiac events related to coronary artery stenosis, heart infarction, pericarditis. I think these are the most important ones, provided you don't exceed tolerances of the spinal cord, for instance, because then, of course, you can have very severe complications like paralysis. but this is something that we absolutely try to avoid. We also see that lymphopenia might happen during a course of chemoradiation because the irradiation of the bone marrow. This is transient, but it has a serious impact on the prognosis of the patient. So patients with serious lymphopenia have worse prognosis compared to patients with less or without. If you go for pre-op chemoradiation, then it's a completely different set of side effects, and it's side effects mainly related to postoperative complications. And again, these can be lung complications or heart complications or both.
And related to that, another question was, is COPD a contraindication for irradiation?
We look at the lung function and the diffusion capacity. This is for us, these are the important parameters to decide. But for us, it's less strict than for surgeons, for sure. So when a surgeon or the anesthesiologist refuses a surgery in a patient, then we can still irradiate. It's only when the lung function is really very bad with low diffusion capacity that we cannot irradiate a patient.
Okay, thank you. In the meanwhile, we have the answers of the third poll. And there, let's say half of the audience is in favor of adjuvant chemotherapy, and 1/3 says, okay, follow-up, no treatment. There's only a minority in favor of radiation or immunotherapy. Any comments?
Data for adjuvant chemotherapy in squamous cell carcinoma are very limited. To my knowledge, there is no randomized trial looking at adjuvant chemotherapy in squamous cell carcinoma. However, at ESMO this year, the Checkmate 577 was presented. This was a somewhat different patient population than this patient, but squamous cell carcinoma and adenocarcinoma treated with a cross regimen followed by surgery. And those patients that did not obtain a clinic or pathological complete remission, they were randomized between placebo and nivolumab. And with 1 year of adjuvant nivolumab, the disease-free survival was more than 22 months compared to only 10 months in the placebo arm. So ESMO was this year in October, and I think it will change our strategy. But this patient, however, he was treated with kind of, was it now pre-op or was it now definitive? Because on the basis of the PET scan, I don't think we would operate this patient because the PET scan showed a very good response and the biopsies were negative. And these perigastric lymph nodes, we could not detect them on the PET scan. So I guess in our hospital, this patient would go in follow-up with PET-CT, endoscopy, and I think endoscopic ultrasound might also have a value for those patients that we treat conservatively, because in the SANO and the pre-SANO study, it was shown that with the combination of these 3 examinations, you get up to 90% accuracy to judge on a clinical complete response. The nodes, of course, were not irradiated, so it only shows that they were not responsive to the systemic treatment, which you can expect because the dose of carbotaxol combined with radiation is on the low side. But it could also be an inverse argument against adjuvant chemotherapy, of course.
Okay, the question was again here, what was the TNM of the surgery was YPT 0 in 1, so it was about 2 lymph nodes, but the primary tumor was completely negative. Any comments, Professor D'Journo?
I totally agree with Karin. Probably, normally, I would suggest to say follow-up, no adjuvant chemotherapy for these patients, but with nivolumab, probably we will start immunotherapy for very recently for this kind of patients.
Okay, then I'll come back to the case. So the patient is currently receiving adjuvant chemotherapy, oxaliplatin, capecitabine, every 3 weeks, planned for 6 cycles, with some mild treatment side effects. This was the first case.
Lieven,
yes.
May I have a comment on the surgical strategies? Do you believe that Ivor Lewis is a good technique for salvage esophagectomy after definitive chemo radiations?
That's a good question. I would say we are talking today on esophageal squamous cell carcinoma, and in squamous cell carcinoma of the upper or the middle third, I would go for the highest lymph nodes as possible. So I would at least go for an McEwen with high mediastinal, and if necessary also cervical lymph nodes. Yeah. What would you do?
Yeah, me too, because of high dose of radiation, probably to reconstruct in the neck, but also I think minimally invasive esophagectomy is quite difficult after definitive chemo radiations, and probably I will do a hybrid McEwen, right open thoracotomy, and afterwards laparoscopy and left cervicotomy.
I would probably do the same. It depends a little bit on the location. If it's indeed middle third, you can expect some difficulties on the airway, and then I would also go for a hybrid procedure. If it is a lower squamous cell tumor, then you can do it full MIE, I think. But indeed, I'm also a little bit hesitant to do it full minimally invasive in the chest because of the airways, indeed. Okay, this was very nice. Let's skip to the second case, and this will be, I think, a little bit more challenging for the audience and for the experts as well. Let's see. There comes the second case. Second case is a 60-year-old male with 5 pack years. He stopped already in 93. History of alcohol abuse, which he stopped in 2012. He had several knee procedures. His father died from throat cancer. He had a brother with pancreatic cancer. He has a BMI of 31 and has actually no weight loss. And since a few months, he has a globus feeling and swallowing difficulties. And the ENT examination showed pharyngitis in the beginning, but after a while, it didn't. It was still there, and he got a barium swallow, which looked like this. And you can see that there's quite some abnormalities in the upper esophagus. So an upper GI flexible endoscopy showed the stenosis just behind the upper esophageal sphincter, so on 18 centimeters from the teeth, very high. It was difficult to pass with the scope, and once passed, there was a normal esophagus and also the stomach more distally, so the only problem endoscopically was very proximal. A biopsy showed a moderately differentiated squamous cell carcinoma. The PET-CT, I'm sorry, the PET-CT is in here. What we are seeing is huge lymph nodes in the neck, and then a few mediastinal lymph nodes with the tumor. I will go back to show you, because for the rest there was nothing really. So here, supraclavicular lymph nodes, then the upper mediastinum, paratracheal lymph nodes, and the tumor behind the trachea. Another lymph node, and then further distally, there's nothing anymore. Bronchoscopy was performed. You see a bulging of the membranous part of the trachea here. And the vocal folds are normal. What would be the clinical stage, according to the audience? Is it C3 in2 M0, C3 in3 M0, C3 in2 M1, C3 in3 M1, or CT4 because of the trachea, the bulging there, in2 M1 or T4 in3 M1? You can vote, and I'll try to come back to you. In the meanwhile, there were some questions. A question about radiation zone choice. I think it's about the field. Are there any differences for first, second, and third part of the esophagus? So what lymph nodes will you take in the field if you only have, like in the first case, I think only the tumor and there's no specific lymph nodes that seem to be involved? What would be your field, Mr. Haustermans?
It's very well described in the guidelines, I think, of the difference between cervical, middle, and lower, and especially with regard to the perigastric lymph nodes. But in general, pathological lymph nodes should always be included in the volume, and not only the node itself, but the whole lymph node area. And then also the lymph node areas, the draining areas. So we will include the perigastric lymph nodes and the nodes around the celiac artery for lower esophageal cancer GE junction, and of course cardia in case we irradiate it. So indeed, it makes a difference where the primary tumor is located, and also whether there are positive lymph nodes or not on staging examinations. That also will have a serious impact on the volume we irradiate. There is also a question on how long segment of the esophagus we can irradiate. Yeah, we can irradiate the whole esophagus if needed, but the problem is, of course, toxicity, so we always have to watch the dose constraints to the organs at risk, and also question the aim of the treatment, because of course we can irradiate everything, but it should still be with a certain aim. And in case of curation, I think it's extremely rare to cure a patient that has such a large tumor. So in those cases, I would not go for radiotherapy, but for palliative chemotherapy.
Okay, but imagine you have a low tumor, distal third, you have one or two lymph nodes paraesophageal in the upper mediastinum. Would you go for one field, for two fields?
This is where we had a very long discussion in our panel, and it was decided that the two options are valid. So you can either have two separated volumes or one continuous volume, and in Leuven we decided to go for a continuous volume because in our opinion it's the lymphatics that drain upwards, so all these lymphatics are also at risk of containing tumor cells. So we do it as a continuous volume, but the guidelines offer the two options. So it's up to the treating radiation oncologist.
Okay, then I come back to the surgeon. What do we do with the thoracic duct?
I think we have to resect the thoracic duct to respect the oncological principles of Bob Skinner, who defined the en-bloc esophagectomy. You must clip and ligate the thoracic duct at the bottom of the chest for oncological purposes, but also to avoid chylothorax.
Okay, then we go to the poll. Most of the people are saying this is a CT3 in2 M0 or a T3 in3 M0. So I was just thinking on the supraclavicular lymph nodes. Are they regional? Are they metastatic? That's a bit of discussion, I think. Any comments?
For the case, Benoit and myself, we also discussed on it, and Benoit, correct me if I'm wrong, but when looking at the images, we thought it was more like periesophageal lymph nodes and not so much supraclavicular lymph nodes.
Yeah, I also
think
it's
regional lymph nodes, right?
Mm-hmm.
Regional lymph nodes according to the TNM classifications. For me, it's a T3 because you have an obstruction of the esophagus. N2 or N3 is difficult. It depends on the numbers of invaded lymph nodes, but the bulky lymph node at this level, I think one bulky equal 2 lymph nodes positive. So for me, it's a T3, N3, non-resectable squamous cell carcinoma.
Okay. Then we go on with the case. What is the treatment plan? And maybe I immediately ask the next question as well, in the sake of time. So first, the treatment plan. And then second, what is your feeding plan? Treatment plan: surgery, pharyngoesophagectomy with bilateral neck dissection, surgery being a glottis-sparing esophagectomy, neoadjuvant chemoradiation therapy followed by a total esophagectomy, or followed by a glottis-sparing esophagectomy, or definitive chemoradiation on the tumor and the regional lymph nodes, followed by a bilateral neck dissection, or with a potential bilateral neck dissection. And of course, another one can be, we just go for palliative chemotherapy. And then the feeding plan would be peroral feeding. We just keep it as it is. Could be a bit difficult, but it still is working because the patient didn't lose weight. We do a gastrostomy, we do a jejunostomy, or we go for parenteral feeding. You already commented a little bit on what your idea was.
For the strategy, definitive chemoradiations, and to propose lymph node dissection in very, very selected cases, probably according to the response to the treatment, and for remaining tumors at the end. And for nutrition protocol, not peroral endoscopy because he had an obstructive tumor, probably jejunostomy to avoid infection related to parenteral nutrition.
Okay. Any comments then on jejunostomy versus gastrostomy?
I think gastrostomy is more tolerated, but jejunostomy is probably more easier. It depends on the cases, I think.
Okay, so that would also be an option.
Depends on whether or not you go for surgery.
If you plan to use the gastric to make surgery, it's probably better to not use the stomach or gastrostomy, even if you can perform a gastric tube with a previous gastrostomy. It depends. I think it's not something that can be definitive.
Okay. Indeed, if there's a chance that we are going to use the stomach in the future, then I would definitely go for a jejunostomy. In this case, the chances are low, I think. So there we can go for both indeed. I go back to the case. Oops, something happened. So the treatment was started, definitive chemoradiation therapy on the tumor plus locoregional and the cervical lymph nodes, but we also said these were locoregional, 70 gray in total. The mediastinal lymph nodes got a bit less, 54, I'm sorry, and the patient got a laparoscopic jejunostomy. There was a re-evaluation PET-CT 6 weeks after the end of the radiation therapy, which showed a moderate uptake on the primary tumor, probably inflammation, moderate uptake on the both upper lobes of the lung, complete response of the paraesophageal and the paratracheal lymph nodes, and a slightly residual uptake in the periphery of the supraclavicular lymph nodes, and no other lesions. So I go back to the zone where we need to look at. There you see the big lymph nodes with a slight uptake in the peripheral zone. And if you go lower, we see probably some inflammation of the esophagus, and all those mediastinal lymph nodes are completely gone. And you see slight uptake in the apex of both lungs, probably also inflammatory. What would be the next step? Surgery, being a bilateral neck dissection only because of those lymph nodes. Surgery being the total esophagectomy with bilateral neck dissection. Surgery being the glottis sparing esophagectomy with bilateral neck dissection. Endoscopy and biopsy and only surgery when negative, and then the neck only. Biopsy and surgery with a total esophagectomy when the biopsies are positive. Endoscopy and biopsy and then surgery when positive, being an esophagectomy and the neck, or it is too early to see response, we do an endoscopic and a PET evaluation in another 6 weeks and we wait. I'm coming back to you. In the meanwhile, we have an interesting question. Should we stop irradiation if we have an esophagotracheal fistula? That's, of course, a big problem. Any comments?
But I think that, first of all, it's very important to stage the patient correctly, and the patient got a bronchoscopy and there was no tumor growth in the trachea. So in my opinion, it's very unlikely that the patient would develop a tracheoesophageal fistula. In case there is a risk, we don't dare to irradiate because that's far too dangerous to lose the patient during the treatment. So if there is a fistula, we'd rather start with a less aggressive treatment, for instance, palliative chemotherapy, and then depending on the evolution, a metal stent. There are several issues with the metal stent, and if there is a stent in place, we try to avoid radiotherapy. The issues are that it's very hard to calculate the dose because of the metal. That's number one. And number two, if the tumor responds well, the stent starts to migrate. So we try to avoid patients, to irradiate patients with stents. So normally we don't do it because of all the difficult issues that you can have with a stent. But on this patient, we had a very long discussion because it was clear for us up front that with these big necrotic areas within the lymph nodes, these huge lymph nodes, he had a very bad prognosis. And that's why we were, I think, a little bit, and rightly so, on the conservative side for surgery, although he was young. And the dose we chose was actually a dose that we use to treat head and neck cancer. And we used a simultaneously integrated boost technique. And so the tumor and the macroscopic nodes went up to 70 gray, but at the same time, we irradiate during 35 times the elective areas, and there we used a much lower dose per fraction, 1.55. So it was an integrated, optimized radiotherapy plan that we administered. But yeah, with such necrotic areas, that's why the option of lymph node dissection was between the choices, because we had long discussion with the thoracic surgeons on this case on what we should do, because we knew up front that with radiation and chemo we would never be able to control these big nodes in the neck.
Indeed, and after radiation therapy there was actually quite a nice response. And we also said, as the majority of the audience, that it was too early to see the response, and we did another evaluation, so 12 weeks after the end of radiation therapy, so another 6 weeks later. And there we saw an increased uptake of the primary tumor, so probably there was still residual tumor. Increased uptake in the periphery of the supraclavicular lymph nodes, which was almost gone but is coming up again. And there was a lesion in the right upper lobe, suspect for metastasis or a primary lung cancer. So I'll go back to the images. There we see the lymph nodes, and especially on the left side you can see the uptake, and in the middle you can see the uptake of the tumor, and then the lesion in the upper lobe was there. Endoscopy shows us this view. We cannot pass even with a baby scope. Biopsy showed ulcerative esophagitis, no cancer for the moment, but this was what we had. Then the question, of course, is what do we do now? And this will be our final question for today. We go for surgery anyway, I'm sorry. We do a VATS wedge of the right upper lobe, followed by surgery. And then, of course, a total esophagectomy with neck dissection. We go for a VATS wedge of the right upper lobe, and when it's negative, we follow. It's followed by surgery. When it's positive, we go for systemic therapy, and that's the fourth option, being systemic therapy. Okay, you can vote on this one as well. And I heard there were some questions coming in. In patients with clear indications for preoperative radiotherapy, would you contraindicate stenting and indicate jejunostomy or gastrostomy? And there was already an affirmative answer of Professor Haustermans. Any other comments from Professor D'Journo?
Jejunostomy is very useful, and it's very easy to do that laparoscopically. Stenting, it's problematic with radiotherapy, and especially in a neoadjuvant treatment setting. So probably I would suggest jejunostomy or even gastrostomy.
And even that high up in the esophagus, it will be very hard to put a stent, no?
Yeah, in this case, for sure, but also in other, let's say, smaller tumors and more distally, these stents give a lot of inflammation. It's very hard to operate on afterwards. And if you only do this to open the esophagus to give the patients the idea of having some peroral feeding, you can better place a jejunostomy for sure. And in most of the cases after radiation therapy, the esophagus opens up anyway, so then you can give the patient any peroral feeding he wants, and you can combine both. So I also agree for sure. Does a nasogastric tube affect radiation therapy?
Not at all, but it's very unpleasant for the patient, so we try to avoid it.
Indeed, it can be an alternative, but if you have this in place for more than a few weeks, you can see necrosis of the ala of the nose. You see horrible things, and it's very uncomfortable for the patient indeed. Any role of plastic stents?
A higher rate of migration with plastic stents. Is that the problem?
They in my opinion, they never are in place anymore after a few weeks. So no, yeah, I agree on that. Let's go back to the poll.
The role for metallics is only in the very palliative setting, where the life expectancy of patients is low, short. There can be a role for a metallic stent, but patients with a reasonable life expectancy, there is a randomized trial showing that they benefit more from brachytherapy in that case. But from radiation compared to a stent, because the effect is longer than with a metallic stent. So only if the life expectancy is 4 months or less, you can consider a metallic stent.
Okay, thank you. We all, or most of us, let's say 2/3 of the audience, agree on the fact that we should go for a systemic therapy. Of course, you can do a VATS wedge to see if that makes any. We also discussed on that, and that's why these options are there. But anyway, it's very fast after the end of the radiation therapy, so the chance on a metastasis is very high. So we also chose in this patient to go for systemic therapy, and the patient is actually on nivolumab right now.
Two options here based on recent studies. That's either chemo with pembro or nivo or pembro immunotherapy in the first line of metastasis squamous cell carcinoma. I think you have the two options there. But I think because of toxicity, they prefer to go for monotherapy with immuno.
Okay. Any other comments, Professor D'Journo?
Best supportive care, I think, or definitive chemotherapy. There is, I think, no place for VATS. If you want to document the nodes of the right upper lobe, you can use CT-guided biopsies, but the chance to have a synchronous lung tumor associated with this very huge tumor, very small, it's probably going to be metastatic patients. So systemic therapy and probably immunotherapy in this case would be the future for these very selected patients.
Okay. There's one other question coming up. In case of an esophageal pleural fistula due to the tumor, what would be the next treatment plan?
I would suggest stent.
There, I think it's indeed a good option to stent. And if necessary, I think you should drain the pleura, of course, depending a little bit on the case, but it doesn't look that good. Yeah. Could the nodule in the lung be because of irradiation? Professor Haustermans.
But the bed nicely illustrated the risk of radiation pneumonitis due to the radiation. And you could almost see the incoming beams on the PET scan where there was some FDG uptake, but the pattern is completely different. It's not a nodule, it's really a beam that you see on the PET. And in this case, it was clearly visible. And at 12 weeks, it was even worse than at 6 weeks. So it nicely illustrates that you have to be extremely careful about the lungs when you irradiate to high doses.
Indeed, there was a remarkable difference in the apex of the lungs. There you saw the problems after irradiation therapy, but the nodule was something completely different. Yeah. Is there a risk of primary lung cancer after irradiation?
That's correct. But these cases,
very early, no?
Secondary lung cancers after radiation, it takes at least 10 years to occur. So between 10-15 years, you can get a secondary radiation-induced lung cancer. And this typically happens to children irradiated when they were a kid and to patients treated for Hodgkin's disease in the 80s and the 90s. They are at a higher risk of developing lung cancer when they got this mantle field irradiation. But in this case, it's only, 3 months after the end of chemoradiation, so this is not radiation-induced.
Just a question, in the case, because we have several cases in France of that, young patients with previous breast cancer who had or Hodgkin disease, who had previous radiotherapy, and you have a small T2 and T2, T3, N0 seems resectable. What is the best protocol? Is it possible to add a new irradiation, or it's a good candidate for surgery first line?
Unfortunately, we've seen several cases in our clinic where patients irradiate to the parasternal lymph nodes in the 90s, they developed radiation-induced squamous cell carcinomas of the esophagus. And what we then try to do is to reconstruct the previous irradiation, and then we try to still irradiate them in the pre-op setting then, because to go back for a full course of chemoradiation after previous treatment with radiotherapy in that area is usually not possible. But these radiation-induced cancers, overall, they have a worse prognosis than the non-radiation-induced cancers.
And I can tell you surgery is difficult also.
Yeah, because there is fibrosis and
you have to reconstruct in the neck to avoid fistula and to use another route, and especially a retrosternal route in this case.
One of the reasons why they might have a worse prognosis is because it's very difficult to treat these patients in an optimal way. But the bottom line, of course, is they could only develop a secondary cancer because they were cured of the first.
That's also true. Okay, great. We are it's 7 o'clock or past 7 o'clock. For me today, this was a great webinar. We had over 100 live attendees, which never happened before for an esophageal webinar. We had many interactions. So on behalf of the ESTS Learning Affairs Committee, I would like to thank our experts, Professor Haustermans, Professor D'Journo, for the excellent webinar today. And of course, you, the audience, for your interest and interaction. I hope to see you again next year. It will be next year for the next expert lecture on the coronal resections and reconstructions by Professor Klepetko from Vienna. In the meanwhile, I wish you a warm end of the year with you and your family, and I hope that things will get back to normal in 2021. Thanks again and stay safe.
Thank you. Good evening.